let's talk a little bit on the material side of things.
Okay.
One of the things I was really impressed, and again, this is a unique seat that we have in our role to even be in a CE course like we were in today, alongside you and Dr. Blatz and Dr. Ratana, and watching, sitting in the back with a room full of dentists. And I do not have DDS at the end of my name, and hearing about the materials and hearing about gold. I had no clue that gold was such a good material for restorative teeth. I thought it was just something that hip hop people love to do, or that it was something that that you might have as a last resort, maybe because you'd see it in older people, right?
Yeah.
You would see it in older people. You'd see gold teeth, and the problem with it sticks out like a sore thumb, right? You smile and it's ting. I mean, that type of deal. But it's a really good material. Why is it a good material? I want to start from the back, and we'll get to where we are now.
Yeah. So as you say, you've seen this in older people. It has a lot of durability. The material absorbs the forces of mastication very well. It has also a very similar behavior to dentin and enamel.
Okay.
So over time, it wears as normal teeth does. So we would always think the hardest, stiffer material will always be the best, and not necessarily. It's the one that absorbs the forces and adapts to these stresses through time, and also might not be the most aesthetic material, I would say. To be honest, I wouldn't get my central incisor on a gold crown. I would prefer a porcelain or a zirconia restoration for sure.
Right.
But longevity, it's really good, because once we cement a gold restoration, we can burnish it and polish it in a way that it's basically sealed on the margin to the tooth. So there's less, let's say, risk of getting secondary decay or secondary caries.
So let me sum up. What's mastication?
Chewing.
Chewing. Okay. So what you're saying is that you've got the ability to now, with the materials, instead of you might have a harder material that doesn't wear with your natural dentition, right? Your natural teeth as well. So it might be harder. You got softer teeth. It might not. But gold, going back to that, when you polish it and all that, it is as close to your, from a secondary substance as you can get to your natural enamel and teeth.
Yes, exactly. It's very similar, and if you have something that it's extremely hard and stiff, the material won't give, but the tooth will, and the tooth will fracture, and then that's a catastrophic failure, and we're done. We've got to extract the tooth and think for solutions. With gold, we have that advantage that the gold will be, in a way, not so aggressive towards the neighbor tooth, to the opposing tooth, and that's why these gold restorations sometimes last forever, right?
Oh my gosh.
What we're doing now in the ceramics world is that we're combining, and now we have different options, like for example hybrid ceramics that have a stiff content, but we also have certain percentage of composite or fillers that make them better shock absorbing materials. So it's important to always understand that the maxilla and the mandible are different. The maxilla is stiff, it's anchored to my head, while the mandible is always in movement and it's supported by the muscles. So the mandible is always the one that is hitting the maxilla. the bone density is different in the mandible compared to the maxilla.
Really?
The maxilla is more like a cork, like a wine bottle cork. It's very
The
soft.
top is soft?
So you might need more implants, or we prefer to place more implants to have a stronger foundation. While the mandible is more like, let's say, a hardwood. Okay, so with 4 implants, you might be perfectly fine for many of the cases. So that's where the clinician needs to have the understanding of the big picture of the different materials to provide the patient with the best indication. Sometimes you see trends or clinics that only one material for everyone, and we don't agree on that. We think that, yes, for example, zirconium oxide, it's a great material for full arch restorations. It's very strong, it's durable as well. We can use it with technology, but we need to see the amount of reabsorption that the patient had and how high that new zirconia implant bridge will be, how much that implant bridge will weigh. And if it's going to be in the lower, that it needs to be supported by the muscles, maybe it's like I'm walking with my backpack full of weights all day long and I feel tired. So zirconia is great, but still in 2021, we need to put much attention on treatment planning, patient by patient, and not come with solutions that we think would work for everyone.
Which is why when I was doing my homework back in the day and getting to know this process, why some clinicians will do a zirconia upper and maybe a hybrid lower because of the weight and on the lower jaw part of it, right? And then also what does that do to your bite?
Yeah, that's a good point you're bringing up. When we have the natural teeth, we have a periodontal ligament around the root of that tooth, which is kind of the suspension of your car or your bicycle, okay? That absorbs the forces of mastication better. With implants, these implants are anchored to the bone, so we don't have that periodontal ligament in a way. So if you have full zirconia upper, full zirconia lower, we cannot control really the forces, okay? And many times the maxilla, as I said, has less density, suffers more. And in the mandible, because the muscles of mastications hold the mandible in place, they can feel tired or overstressed. So combining something lighter in the mandible and something stronger like zirconia in the maxilla is something that makes sense. Going back to my point, we need to treatment plan case by case to make sure we give the best solution for every patient. I wouldn't generalize like one solution fits all.
Yeah. Not everything's a nail and all you have is a hammer.
Yeah, exactly.